Welcome to the Pulmonary Hypertension Blueprint, a systematic algorithm for pathophysiology, diagnosis, and targeted management. Pulmonary hypertension is defined by a mean pulmonary artery pressure, or MPAP, greater than 25 mm Hg measured at rest. This threshold distinguishes normal from pathologic pulmonary hemodynamics. High pulmonary pressure creates a right-sided domino effect. This leads to symptoms such as progressive dyspnea, and signs like jugular venous distension, and signs of right ventricular strain or abdominal overload. The diagnostic funnel for pulmonary hypertension involves a four-tiered approach. It progresses from the initial clinical presentation and screening tests, to the etiology hunt, and finally, to a definitive diagnosis via right heart catheterization. Initial screening with transthoracic echocardiogram, or TTE, estimates pulmonary arterial pressure. It also evaluates the left heart and detects anomalies, such as right-to-left shunts, using a bubble study. Pulmonary imaging, like chest X-ray and pulmonary function tests, reveals vascular pruning in pathologic cases and helps uncover underlying lung disease. The etiology hunt involves testing for systemic and underlying triggers. This includes serology for autoimmune and infectious causes, liver function tests for hepatic/portal causes, and a sleep study for respiratory triggers like obstructive sleep apnea. For chronic thromboembolic pulmonary hypertension, or CTEPH, the VQ scan is the preferred test, being highly sensitive for microvascular flow abnormalities. A CT pulmonary angiogram should be used only if the V/Q scan is positive. Right heart catheterization is key to confirming and staging the diagnosis and severity. It evaluates left heart pressures and includes a vasodilator challenge to predict the patient's response to oral therapies. The management paradigm differentiates between primary disease, Group 1 PAH, and secondary disease, Groups 2 to 5. Primary disease targets the pulmonary vasculature directly. Secondary disease focuses on treating the underlying condition first. The vasodilator challenge dictates the utility of calcium channel blockers. If pulmonary arterial pressure drops significantly, the patient is vasoreactive and may respond to oral CCBs. Otherwise, proceed with advanced vasodilator therapies. Group 1 PAH therapies directly target the pulmonary arteriole through three key mechanisms: prostacyclin analogs, ENDO-THELIN1 antagonists, and phosphodiesterase inhibitors. Adjunct interventions include diuretics for volume overload and supplemental oxygen for hypoxemia. Anticoagulation is mandatory for Group 4 CTEPH. Transplantation is an end-stage option when maximum medical therapy fails. The WHO Group Diagnostic and Treatment Blueprint outlines distinct paths based on etiology. Remember, diagnosis is a checklist, and management is a targeted strike, focusing on the etiology to dictate the therapy.